Hi, I'm Lauren Moskowitz, and I'm a faculty member in the psychology department at St. John's University. I'm here today to talk about how you assess and treat anxiety in children with autism spectrum disorder and a comorbid intellectual disability. Many of you might have already seen Dr. Judy Raven and Dr. Audrey Blakely-Smith's wonderful video on how to use CBT for children with autism spectrum disorder to treat their anxiety. And I'm just going to add a few modifications for how you assess anxiety and how you treat it in children with autism spectrum disorder who have a comorbid intellectual disability or who are minimally verbal. So in terms of assessing anxiety in these children, it's a little bit harder because, as most of you know, in CBT, the model of anxiety or any emotion is that it's made up of three components: the cognitive component, the behavioral component, and the physiological or affective component. And in kids with autism who are minimally verbal, that behavioral component is easier to assess, but the more difficult part to assess is their thoughts or their feelings. That's subjective, the thoughts of worry or dread, and the subjective feeling of anxiety. That is really part of the construct of anxiety. So what we would recommend is to try to do a really thorough multi-method assessment of anxiety using a combination of interviews, questionnaires, and of course direct observation of idiosyncratic or unique behaviors that may indicate anxiety in children with autism. For example, clinically speaking, some children, might engage in the typical behaviors like freezing or clinging or running out of the room or cowering. There's also some typical facial expressions indicative of anxiety with downturned eyebrows and frowning. But sometimes you see a more unique or idiosyncratic presentation, such as children humming in a kind of escalated speed or using specific perseverative phrases that indicate anxiety. And so it's very important to try to identify from parents and teachers what are the behaviors that indicate anxiety in these children, and to try to use parent report and ideally child self-report if you can to get a sense of the situations that make them anxious or afraid. One complicated thing is to try to distinguish this anxiety from situations that they just dislike. And one way you can do that is by noting the behaviors that are similar and different in situations that children don't like, such as maybe doing homework, versus situations that make them anxious. So in terms of treatment, we use the same components that Judy Raven and Audrey Blakely-Smith discussed in terms of cognitive behavioral therapy, and what that consists of is cognitive restructuring. We're trying to get children to think about their anxiety differently, think about anxiety-provoking situations a little bit differently, and if there's any other way to look at that. And for children who have an intellectual disability or who are verbally limited, the cognitive component of CBT is often de-emphasized or modified somewhat. We try to make it a lot more concrete, use a lot more visual supports and lists, which is also used for children on the spectrum in general, not just those with ID. But we try to make it very, very concrete. I try to convey the psychoeducation and cognitive restructuring component of CBT through social stories often, or through video modeling, or some other type of visual representation to really make it clear to the children. So not just verbally, as I might with neurotypical children. And another thing in terms of one of the main treatment components, of course, is graduated exposure. And ideally, this is something, of course, we use with all children on the spectrum who have anxiety. In some cases, children with ASD and ID might present with such severe aggression or self-injury that we may need to use more of a counter-conditioning approach that you find in some of the older behavior analytic literature, where the anxiety-provoking situation is paired with something very, very highly preferred. I would even argue they're perseverative interests. As we know, kids on the spectrum have very, very strong perseverative interests often, and sometimes those perseverative interests are the only things that can overpower or counteract their anxiety. So what I do a lot clinically is if a child might be too aggressive or engage in too much self-injurious behavior in the context of graduated exposure, we'll pair that anxiety-provoking situation with something that is their perceptive interest. So pairing the doctor's office with Potato Head, for example, or for a child who was afraid of left-right turns, pairing driving in the car with a recording of his favorite Dr. Seuss stories, which was his perceptive interest. So in that way, we were able to sort of attenuate the influence of the anxiety-provoking situation. And finally, another strategy we use a lot is some of the antecedent-based literature from the applied behavior analytic and positive behavior support literature in terms of increasing predictability via visual supports or timers or countdowns or video priming or video modeling. All of these are ways to make situations more predictable, which can help to alleviate children's anxiety while you're teaching them the coping skills to be able to cope with their anxiety. And that's about it. And thank you very much for joining me.